Congresswoman Sherry Bustos.
Thank you, Madam Chair. And Dr. Rivers and Dr. Frieden, thank you very much for taking the time to be here with us today. I want to ask you about COVID-19 in rural communities. It's the district that I represent in the northwest corner of the state of Illinois. 85% of the towns are 5,000 people or fewer. 60% of the towns are 1,000 people or fewer. So that gives you a picture of the kind of district that I represent. There are people who think that COVID-19 is less serious in rural areas and outside of, not highly populated, not high density of population. And so a couple examples that I want to share with you of what we're seeing in this congressional district. We have 102 counties in the state of Illinois. Two of those counties, one is called Warren County, which is in the congressional district I serve, has a population of about 17,000 people, so not a large population. It now has the 5th highest number of cases per capita in the state of Illinois. Another county is Stevenson County. It's on the Wisconsin state line. Has a population of about 44,000 people. The number of cases, COVID-19 cases there, are doubling every 5 days. All right, so that is the 3rd fastest rate in the state of Illinois. So just want to give you a little perspective. So, I know, like, if you look nationally, we have many, many governors now who are pushing for our country to reopen, and certainly in their own states looking at reopening. And there are also these ideas that we can reopen in a state in tiers, where it's less populated and versus where it's more populated. So wondering if you can address that along the lines of what resources and practices do we need to know in more of these rural areas? What do we need a certain level of testing? Maybe if you can just drill down of how it's different in rural America versus, cities like Chicago or New York. And this is addressed to both of you. I'd like to hear from both of you on this, if I could, please.
Well, first, I would say that in general, the challenges in urban areas may be more severe. What to do about crowded subway systems, bus systems, very close quarters in the U.S. and globally is something that we have not yet figured out and is an enormous challenge. But no area is immune. We don't have immunity to this virus. And in each community, there may be nursing homes, there may be factories, there may be other facilities where there is potential for a lot of spread, and there may be less access to the kind of intensive care that is needed in some rural areas of the country. I think something Dr. Rivers said is really important to highlight, and that is the importance of data. We are learning more about this virus every day. The famous Nobel laureate Josh Lederberg used to say, "The microbes outnumber us. It's their numbers against our brains." And we have to use intelligence to figure out what the weaknesses of the virus are, to understand, for example, where it's spreading, what are the highest risk things. I talked about 2 dichotomies in my testimony, open versus closed. It's really a question of degree, different things. A second was public health versus the economy. In fact, together we can resolve them. Another false dichotomy is safe and risky. It's really safer and riskier. So we need to make as much of our environment by design, by changing the way we go about our business, as safe as possible, reduce risk, and we'll do that by understanding more through things like contact tracing where the disease is spreading and how to reduce its spread most effectively.
Thank you.
I would just add that rural areas have seen less explosive growth, which is encouraging, but they also tend to have less capacities. And so I worry that a community may have a manageable level of transmission until a congregate setting like a correctional facility or a nursing home becomes infected. And then suddenly the local hospital might have 25 high acuity patients that need to be admitted, and that hospital might not be able to accommodate that. And so I think that's the kind of surge capacity that we need to be planning for, is supporting rural communities when they do have a change in their epidemiology.
I've got 34 seconds left. Rosa, may I ask a second question that follows up on this? So speaking of correctional facilities, we have 2 federal prisons in the congressional district I serve. And I don't know if you've been following this case this topic very closely, but the Marshal Service has turned over inmates to the Bureau of Prisons to go to 11 different prisons throughout the country for transfer of patients that are not tested for COVID-19. One of those prisons is in Thomson, Illinois. This is in a county called Carroll County, 0 hospitals there. You'd have to travel over across the Mississippi River to Iowa to go to a hospital, or a county to the north or a county to the south. Wondering about screening, the proper screening that should happen before the transfer of any patients, or I'm sorry, any inmates to another prison. If you can talk about what would best practices look like for transferring prisoners from one facility to another.
Well, the best practice would be to minimize transfers, first and foremost, because anytime you're mixing more people, you're creating the possibility of explosive spread. You would certainly want to ensure that no one who's symptomatic is transferred. The challenge is that we recognize that there are a lot of asymptomatic people, some of them pre-symptomatic, they'll develop symptoms in the next couple of days, and some of them will remain asymptomatic, and they do appear to be able to spread the infection. That's why even symptom screening will be a problem, and in every congregate facility, we need a comprehensive approach to reducing the risk that the virus will get in, increasing the likelihood we'll find it quickly if it does, and improving our ability to stop it from spreading widely if it's spreading.
And I would just add, if there was an opportunity to use diagnostic testing, one misstep or miscalculation that people sometimes make is to think that just because you have a negative diagnostic test means you're not infected. The situation you would want to avoid is when you test someone early in their incubation period, and so they're already infected, but there's not enough virus yet for the test to pick up, and so it builds over the coming days, and you think you're in the clear and you're not. So coupling or timing the testing with a quarantine period would be recommended.
All right, thanks to you both. I yield back.
Congresswoman Herrera-Butler. Thank you, Madam Chair. One thing, and this is probably for both y'all, one thing we've learned from this pandemic is that the importance of domestic production.